Okay, so we are just gone 1 o'clock. We still do have people joining, but I'll make a start and then people will join throughout the introduction, really. So hello and welcome to this Meet the Expert SHOT webinar. And today's webinar is on haemolytic transfusion reactions and haemoglobinopathies. There will be a presentation for around 30 minutes with some time following for questions and answers. But before we begin, I'd just like to run through a few housekeeping points to help the session run smoothly as possible. So your microphone has been muted by the host and will remain muted throughout the session to minimise the background noise. The chat facility is not available, so please use the Q&A box for any questions. If there is a question you see and you'd particularly like it to be asked or answered, please support it using the arrow buttons to upvote it. If we're unable to answer all questions during the session, you'll be very welcome to email us afterwards. Live captioning is now enabled. You can switch this off if you don't require it. And at the end of the session, we'll be running a quick poll to gather your immediate feedback. We'd really appreciate your input into that. And finally, attendees are encouraged to record their learning from today's session, and you can log 1 CPD point for attending this webinar. So to move on, our presenters today are Tracey Tomlinson, who is the National Lead for Patient Blood Management. Victoria Tuckley is the SHOT Laboratory Incident Specialist. Nicola Swarbrick is our other SHOT Laboratory Incident Specialist. Joining us a bit later, we also have Dr. Anicee, Danaee, who is the Haematology Consultant at Guy's and St Thomas's NHS Foundation Trust, and also Dr. Joseph Sharif, who's Consultant Haematologist at Manchester University Foundation Trust. So today we'll be covering the 2024 annual SHOT report data, which includes cases and key findings, haemolytic transfusion reactions, which are acute and delayed, and hyperhemolysis, hemoglobin disorders, and as I said, we'll be having a question and answer session as well. So before I start, I'd just like to clarify a few important points about the data we'll be presenting today. All cases are anonymised to protect confidentiality. The information we have is based solely on what has been provided to SHOT via the Dendrite reporting system, and the examples are representative of the data supplied, so we can only present the information we know, and that has been shared with us. Everything presented today is for educational purposes only. So thank you for keeping these points in mind as we go through the session, and I'm now going to hand over to Tracey.
Thanks, Emma. So I'm going to start by discussing the haemolytic transfusion reactor chapter from the 2024 SHOT report. So just some headline data to start off with. So in 2024, we had 51 haemolytic transfusion reactions reported. The majority of these were delayed haemolytic transfusion reactions with 21, and then we had 16 acute haemolytic transfusion reactions and 14 cases of hyperhemolysis. The clinical outcome for the patients ranged from no clinical reaction to major morbidity, and we have 3 patients that unfortunately died. What we need to be aware of, though, that the deaths in these cases weren't definitely attributable to the transfusion reaction, but the transfusion reaction did contribute with expected probabilities of either probable or possible. The reactions occurred equally in males and females. So all patients are at risk of a transfusion reaction, and both adults and pediatric patients. The number of pediatric patients in 2024 was slightly higher than we have seen in previous years, but different in 2024, 3 of those reactions in pediatric patients actually occurred in the same child. So one child had repeated reactions to transfusion throughout the year. And haemolytic transfusion reactions can occur with any blood component, but the majority that we see are due to red cell transfusions, and that was seen in 2024 with all of those reactions occurring with red cell transfusions. So the number of reactions that we see remains fairly stable year on year. although the number that, between the acute and the delayed do vary, but we do see that it does remain around the mid-20s with a little bit of a peak or a trough. However, some of these should be avoidable. So that's what we really want to focus on when we're thinking about managing or mitigating against hemolytic transfusion reactions. It's those avoidable ones. So when we're reporting hemolytic transfusion reactions, it's really, really important that we correctly classify that the patient is having a transfusion reaction, and it can be difficult to do that. Patients who are having transfusions are usually having transfusions for a reason. They're unwell, and they're probably already experiencing some symptoms that might mask the transfusion reaction. A lot of the reactions that we see in transfusion reactions, with clinical symptoms especially, are similar to symptoms that you would see in very sick patients. And this is even more difficult when you start looking at patients who have some underlying long-term chronic hemolysis or anemia. So things like hemolysis you might see for a number of different diagnoses, the same with fever, pain, vomiting. So sometimes it can be very, very different. So what you need to do is make sure that you look at the overall picture, not at any one thing in isolation. One of the reasons it is so important to correctly diagnose a transfusion reaction is so you can then treat the patient appropriately. So what we don't want to do is misdiagnose a patient of having a reaction and then failing to treat what actual underlying condition there might be. And so it is really important that we work it out. And also it helps us to manage our patients in the future so that we know whether, we need to be extra vigilant next time we need to make special requirements for that patient's transfusion. And then equally as important, we need to be able to report it correctly, because we use the data from hemovigilance to help us make sure that things become safer in the future. So to help us classify reactions, what we accept for SHOT is hemolytic transfusion reactions can be either acute or delayed. For hemolytic transfusion reactions, the antibody is usually implicated, so it's a specific antibody specificity. And in those reactions, the red cells, the transfused red cells, which are antigen positive, are destroyed, not the patient's antigen negative own red cells. In hyperhemolysis, there's not always an antibody. There can be, but it's not always antibody mediated. And in hyperhemolysis, which is different from hemolytic transfusion reactions, the patient's red cells are destroyed in addition to those transfused cells. So they can be acute or delayed. If you can just flick all of those 4 boxes to come up. And what we need to remember is that the timeframes are different for hemolytic transfusion reactions and hyperhemolysis. So in hemolytic transfusion reactions, an acute reaction is within the first 24 hours post-transfusion, where in hyperhemolysis is considered acute if it's in the first 7 days post-transfusion. And equally delayed is extended as well in hyperhemolysis transfusion, so it's post 7 days. So just looking at the acute transfusion reactions first. So the antibodies implicated in acute transfusion reactions can vary. In the 16 that were reported, they did vary from ones that we know are very clinically significant and we search for on our screening cells, to antibodies to low incidence antigens and very rare antibodies as well. What is important to remember is all of these levels are low. So it's 1 or 2 cases where this antibodies was implemented on each occasion. So it's difficult to determine conclusions. Like, you'll always get acute transfusion reactions with certain antibodies because it does vary and it is low levels that we see, fortunately. Next slide. An example of an acute hemolytic transfusion reaction is a patient who is admitted to a gynae ward in her 40s with meningioma. So she was heavily bleeding and her HB had dropped. She was issued 2 units of red cells and they were issued by electronic issue. Within that particular hospital, there was no history on that patient within their limbs. The first unit was transfused without issue, but 20 minutes into the second transfusion, the patient started to develop symptoms of distress, including shortness of breath, difficulty to breathe, restlessness, shoulder, tachycardia, and hypertension. So the transfusion was stopped and a transfusion reaction investigation was performed. Within the laboratory results, if you remember, it was electronic issue, which would suggest that the antibody screen was negative post-transfusion, and that was the case. When they repeated the antibody screen pre and post-transfusion, it was negative, no red cell antibodies were identified. But when they performed a serological cross-match against the implicated unit, they found a positive result. So they then went on and investigated that further, and they actually identified an Antis-Lewis A using different technology and different techniques. So that's one thing that we need to bear in mind, is that there's not one perfect solution for detecting everything, and antibodies do like to cause us challenges and be detectable in different techniques and technologies. In this case, the patient fully recovered. Next slide, please. Thank you. So just talk a little bit about delayed hemolytic transfusion reaction. Whereas in acute transfusion reactions, we see a variation of the antibodies that are implicated. Within delayed transfusion reaction, we see that anti-JKA and JKB are frequently associated with delayed transfusion reactions. And we saw that in the 2024 data, with the majority being caused by anti-JKA. The reason for that is that antibodies to the KID system are known to drop to undetectable levels quite rapidly after identification. So this shows why it's so important to keep robust information about your patient's transfusion history and their antibody history. Next slide. So a case of a delayed transfusion reaction was an elderly male who was admitted into a general ward with a low HB, and a request was made to transfuse 3 units of red cells. Again, the antibody screen was negative, so they were issued by electronic issue. In this case, the patient felt well immediately following transfusion, went home. 5 days post-transfusion for a routine follow-up, they noticed a drop in the HB, and the doctor treating the patient asked for a hemolysis screen to be performed, and signs of hemolysis were seen in the patient's blood results. A repeat group and screen was tested, and that sample identified a weak anti-JK, it wasn't their pre-transfusion, and a positive DAT, which was 3+. Again, in this case, the patient recovered fully post-transfusion. So key findings. The number of reports, as I said, for HTR does remain stable each year. Within delayed hemolytic transfusion reactions, we do see that antibodies to the KID system are most commonly implicated. However, in acute transfusion reactions, we do see it varies a lot more. And all the cases of hyperhemolysis within this year were in patients with sickle cell anemia. We do see cases in other patient group, but they definitely occur more often in patients with that within that group. Common gaps that we've seen throughout the reports, and which were highlighted in the 2024 data, is we see a lot of incomplete investigations with patients with suspected hemolytic transfusion reactions. And as I mentioned at the beginning, it can be quite difficult to diagnose a transfusion reaction because the symptoms do cross over what you see in a lot of disease states, which is why it's so important that we fully investigate whenever we suspect a transfusion reaction to make sure that we are correctly diagnosing and treating. And one of the key tests for the serology for a transfusion reaction investigation, especially for hemolytic transfusion reactions, is the post-transfusion DAT, which you would expect in most cases to be positive or more strongly positive post-transfusion than hemolytic transfusion reaction. And then from there, going on to elution studies. So elution studies are really helpful to helping to confirm which specificity caused the reaction, but we find them very, very inconsistently performed, which means they then have to look at other data to try and identify which antibodies were implicated, which can be very difficult if the patient's got multiple antibody specificities present in their plasma. And also partial information being reported to SHOT makes it very difficult to assess the effectiveness of the treatments and management of those patients. So mitigating strategies for trying to reduce hemolytic transfusion reactions. Now, as mentioned, with a lot of the transfusion reactions, especially the delayed ones, the patient will have a history of an antibody, and it will drop to low levels or it won't be identified prior to transfusion. So what we need to make sure is that we are very careful about making sure that patient history is confirmed before a transfusion, and that includes getting a history from the patient during the consent process, check and see if the patient's got any antibody warning cards, making use of national databases where antibody information or even previous transfusion history might be recorded, and including any information about patient antibodies within any shared care procedures. And ideally, what we'd really like to move towards is having that information on the electronic patient record, which is available to all hospitals rather than on local laboratory information systems that aren't shared across the whole of the country. So moving on to hyperhemolysis. So the number of cases of hyperhemolysis in patients we report to SHOT, we have seen a slight increase, but we know this is still an underrepresentation of the actual cases that occur in clinical practice. So we do need to do more work to make sure that these are correctly captured and reported to SHOT so we get a true understanding of this problem. Again, the majority of these did happen in patients who are adults, but there were 4 cases in pediatrics, 3 of which were acute and 1 was delayed. And one thing to bear in mind with hyperhemolysis, SHOT does consider that all cases of hyperhemolysis are major morbidity because of the associated significant drop in HB that we're going to discuss again in a moment. And therefore, if they are reported to SHOT as a minor morbidity, we do upgrade them to major morbidity as part of the analysis. So a case report for hyperhemolysis, as I said, these mainly occur in patients with sickle cell disorder, and that was true in this case as well. So a patient with a history of red cell antibodies presented into A&E with symptoms of a sickle crisis. So they had pains in their lower back, their legs, and they were saying that the severity report, self-reporting the severity of the pain as 10 out of 10. This patient had been transfused twice in the preceding 7 days prior to this admission. And it was 6 days after the first transfusion that the patient had presented with this recurrent pain, difficulty passing urine, hemoglobin, and other symptoms of hemolysis. They also had raised ferritin, raised bilirubin, and what is quite key in hyperhemolysis case, the reticulocyte level drops very low. And again, they had a positive DAT. So they were diagnosed with hyperhemolysis. They were treated with IVIG steroids, erythropoietin, and monoclonal antibody therapy, and they did recover in this occasion. So it just moving on to the next stage. Hyperhemolysis is a very complicated disease disorder, and it can be acute, it can be delayed, as I mentioned, and it is very difficult to distinguish between hyperhemolysis and the hemolytic transfusion reaction, but it is very important to do. One of the key things we see within hyperhemolysis is that rapid drop of HB to below the pre-transfusion level. And also, like I mentioned, the retics do tend to drop lower in hyperhemolysis. The diagnosis of hyperhemolysis and the pathogenesis of hyperhemolysis is very complex, and our understanding is still evolving. So we don't have a true understanding of what, but like I said, what we do see in hyperhemolysis, which is different to a hemolytic transfusion reaction, is that in hyperhemolysis, both the transfused red cells and the patient's red cells become hemolyzed and destroyed. And that happens by a combination of bystander hemolysis. So that means that all of the red cells, whether they've got antigen positive or not, if there's an antibody involved, or some cases no antibodies are involved at all, will hemolyze. And also you get suppression of the erythropoiesis, so the patient stops producing new red cells as well. The symptoms are very similar to the symptoms you see for a patient who is also in acute sickle crisis, which is another reason why hyperhemolysis can sometimes be misdiagnosed or underreported. And it can be very rapidly progressing, so it can happen quite quickly. Treatment, there are first line and second line treatment pathways, what we're going to discuss in a moment. And as I mentioned, the majority of these cases are in haemoglobinopathy patients, and we do consider it as a major morbidity. So when we're treating hyperhemolysis, we do it in a few stages. So the first line treatment is just to manage those symptoms that the patients experience and trying to dampen down the immune response. So we do that with steroids and IVIG. We then move on to our second line treatment. And for that, what we're trying to do is manage that hemolysis that's happening. We want to try and slow it down and stop that brisk hemolysis. So we do that usually with monoclonal antibodies. And NICE has approved eculizumab for treatment of brisk hemolysis in 2020. We then want to support the patient because, as I've mentioned before, it is very rapid, that drop in HB, and it will drop below pre-transfusion levels, and it will start to hemolyze the patient's own red cells. So we want to support them by giving them erythropoietin to try and encourage them to produce more red cells, and also things that they need to support that, like intravenous iron, folic acid, and B12 vitamin replacement, because all of those are needed for the production of new red cells. And then we need to closely monitor the patients. So what we will do is do serial monitoring to make sure that they're not getting any worse. With hyperemesis, because you do get that rapid bystander, we try not to keep transfusion them. However, we need to balance that against the risk of life-threatening anemia. So if the patient is becoming too anemic, you do need to transfuse. You can't just keep withholding it because of the risks of the patient dying from anemia and blood loss. Okay, next slide. So the treatment of hyperemesis has been evolving over the years. So as I mentioned, in 2020, NICE approved the use of eculizumab for the treatment of rapid hemolysis. And as time's progressed, there's other monoclonal antibodies that have come across. So we started collecting data in SHOT about the treatments being used for hyperemesis in 2020. And you can see quite clearly within this graph that those first line treatments, the IVIG and the steroids, that's still been maintained. It's quite consistent across all the patients, all the years of the number of patients being treated with those. But the use of the second line treatments, the monoclonal antibodies, has definitely evolved over time following the licensing of eculizumab in 2020 and the other antibodies being developed. And again, with the use of the EPO, and it shows how now in 2024, we're taking a much more combined approach, looking at those three different stages in the treatment. So that initial stage, then treating the hemolysis, and then trying to back it up with the EPO and recover. All right, I'm going to hand over now to Vicky to talk about patients with hemoglobin disorders.
Thank you so much, Tracey. So yeah, I'm going to have a little whip through the hemoglobin disorders data from 2024 for you. Lovely. So this is the headline data, similar to what Tracey showed you. The main thing and the major thing you can see is this steep rise in the cases of all SHOT reports for patients with haemoglobinopathies. So this isn't just the reactions, this is all reports that we receive. Unfortunately, we did have 3 deaths, and that's the reactions that Tracey's talked about previously. And then there was also about 10% of cases there that had major morbidity due to either the error or the reaction in the process going on here. So this is a busy slide, please bear with us. I'm obviously not expecting you to take it all in, but it's just to highlight the difference in the kind of events that we see and the difference in the categories. So by far and large, most reports we see are for patients with sickle cell disorder. We see those a higher greater rate, and that'll be things without the prevalence in the population and things like that, alongside other factors. There's different kinds of reactions in both patient groups as well. So for sickle cell disorder, we mainly see hemolytic transfusion reactions, as Tracey's talked about. And then the majority of reactions that we see in patients with thalassemia are actually our febrile allergic hypertensive reactions. So that's the difference between the two groups. But as we can see consistently in both groups of haemoglobinopathy patients, the second most common cause of SHOT reporting is the incorrect blood component transfuse specific requirements not met. So that just reflects the complex requirements and the complex extended phenotype that these patients need, and the gaps in communication and things that doesn't always get consistently applied. I'm going to take you through a febrile reaction for a patient here. So this was a young child, they had beta thalassemia, and they'd come in for a routine red cell transfusion. Unfortunately, during observations for the second unit, so the first unit went went through uneventfully. The second unit, they became unresponsive. They really weren't feeling very well. They had chills, they had rigors, a high temperature, and their heart was beating very, very quickly. So they were appropriately treated. They were given paracetamol, antihistamine, and admitted to the paediatric ward for observation overnight. Thankfully, the team also did lots of other testing just to rule out any other potential causes. So the serology came back negative and the blood cultures showed no abnormalities. So that was all fine. And the patient thankfully recovered and went home the next morning with no further concerns. So there was also a lot of information that we like to see in this report as well, saying that it was dealt with appropriately and quickly and in the patient's best interest. So that was really good to see some good management of a reaction here. This is a contrast of care that perhaps wasn't as suboptimal, but in a different situation completely. So in this case, we have a young fella in his 20s. He had needed knee surgery, and during that surgery, it was a request was put in for 1 unit of red cells. There was no history on this patient, nothing to contraindicate the use of electronic issue, so that's what was used, and the red cells were given. Unfortunately, after the transfusion, it was discovered that the patient actually had sickle cell disorder, and none of their specific requirements were met. So the units weren't extended RH and K matched, and they weren't hemoglobin S negative either. So this really shows that clear communication is needed for people to be able to give the correct treatment to the patients at the correct time. So what are the key findings? What do we see most routinely in reports of patients with hemoglobin disorders? So we've seen that the number of reports are going up and up in each year, and we've had a massive rise. So there might be through to a combination of things. It might be that there's genuinely more transfusions happening. It might be that there's more errors happening, or just that reporting has increased because it's historically an area where we have seen a degree of underreporting happening. We've talked about the differences between the patient groups, so hemolytic transfusion reactions, and we do see a few of those in sickle cell disorder, and Tracey's kind of touched on that about the complexity, the additional antibodies, things like that. And unfortunately, we did have those 3 deaths due to hyperhemolysis in patients with sickle cell disorder this year, which is really sad to see. We've more than doubled the number of febrile allergic hypertensive reactions this year. It's not at the same levels as the HTR, but it has been increasing. So I think we had about 25 overall last year. And as we've talked about, cases where the specific requirements aren't met for these patient groups is an ongoing issue and definitely needs some more joined up thinking to share the specific requirements between all teams. Excuse me. So we have seen that there's a lack of awareness in the general treating community about the specific requirements in these patients, the risks associated with transfusing patients with hemoglobin disorders, and the extra work that is needed. And echoing back to the points that Tracey said, this is even more a problem when patients go on to have a reaction because the symptoms can look similar. It's really tricky to try and differentiate it. So it's really needed to embed more education in the medical community around these disorders, around the specific needs, specifically when patients are coming to an area that isn't their normal area or accessing acute care, things like that. Advice from the haematologist should be recommended for patients with sickle cell disorder if people aren't used to dealing with them. And unfortunately, we did have a case in the chapter, excuse me, this year where a patient was transfused without seeking advice from the haematologist, even though that was specified that advice should be taken. And we also do have some national guidance that's not always adhered to, and that may also be to do with a lack of awareness as well that the advice exists. Excuse me 1 second. Thank you. So these are our learning points for all kinds of reactions and events for patients with sickle cell disorder. So in general, when it comes to reactions, and any good transfusion advice is that people should be transfused in areas where there is expertise and equipment and availability to help deal with any complications. I think we've seen some reports that that's not always happening. And then the risks of these procedures of transfusion, no transfusion is without risk, even when it's a mainstay of treatment. So these risks do need to be identified, they do need to be communicated to patients and parents as applicable. Tracey's talked to you a lot about hyperhemolysis, and it's just a note in this chapter to say that this can occur even when you do have preemptive prophylactic treatment. So it's something to be aware of. And as we've mentioned, that when patients have red cell antibodies, transfusion does carry that significant risk. It's always a risk-benefit situation in these patient groups. And to highlight and end on here that these kind of issues that we've been flagging aren't new. The things that have been known for a while and specifically are more complex in these patient populations. So the 2021 report for titled No One's Listening was commissioned, and this focused on the quality of care for patients with sickle cell disorder. And the findings were really that the care was not provided at a level that was everybody would like to see. Basically, the care wasn't joined up, and there was a lack of awareness. And in general, there was a lot of contributing factors and social attitudes which have been influencing the poor care for this patient population. So I'd advise you to go and have a look at that. It focused mainly on sickle cell disorder, but speaking and I attended a previous webinar with specialists in thalassemia earlier in the week, and they echoed that similar factors are seen in patients with thalassemia. There's also a lack of knowledge there, so it's not. So it's also a problem in those patients as well. Not the same unique situation for sickle cell patients with sickle cell disorder, but there's definitely echoes of that for that patient population as well. So thank you very much. I'm going to pass over to my colleague Nikki now, and she's going to cover the shared care aspects.
Thank you very much. So following on from what Tracey and Vicky have talked about on the particular patient groups, shared care is definitely disproportionately mentioned in cases of haemoglobinopathy patients. They're not the only patient groups. We often see it in transplant cases and patients with antibodies and cancer patients who are potentially treated over multiple sites. Just to let you know from the 2024 data, if it was related to shared care, Vicky and I would have to look for it in the case and mention it specifically. Whereas from the start of this year, when you report to SHOP, we've introduced a new question, which we will mention briefly later in the dendrite questionnaire, that helps pick out those shared care cases to see if shared care has influenced that event. So looking at the shared care cases on the haemoglobinopathy patients from the 2024 data, it has been mentioned. We see it particularly in specific requirements not met. That's probably not a surprise. Not sharing that information between sites, whether that's a paper share or an IT share, where it tends to be that patients aren't being provided with units that meet their requirements, usually phenotype or antigen matched. They often mention communication or gaps in communication. Again, that's probably not a surprise. There are similar numbers to previous years. We see it in wrong components, transfuse, specific requirements, and in the delays. They absolutely all impact on that shared care aspect. Thanks, Vicky. Yeah, so I've just got a quick case, just a slight proviso. We thought this was a really good case. This is actually from the previous year, but we thought it was quite a good case of talking about patients and their empowerment. So a patient with sickle cell disorder was admitted with a painful crisis, and 2 units of red cells were transfused despite the HB being at baseline for the patient. And when we look through the notes and we read the report, the indication for the transfusion wasn't clear. Unfortunately, 6 days later, they had an acute deterioration with hyperhemolysis, and which led to the patient being admitted to intensive care for 7 days. And they absolutely, what Tracey was talking about, they threw everything at this patient. So IVIG, steroids, monoclonal antibodies, and thankfully this patient made a full recovery. The part that we were particularly interested in is on the discharge of the patient. The patient expressed concern that the rationale for the initial transfusion hadn't really clearly been explained to them, and that there wasn't any documentation of consent of the transfusion in their patient notes. So if we just move to the next slide, it was just to remind or reiterate that just how important patient consent is, and including them in those decision making processes and pathways. We certainly see cases where patients have not been included in that decision making. They're not given clear information. They're not included in the pathway. So there's the most recent guideline was out just in the summer this year. There was more documents to follow. We're just waiting for a little bit more information on the government website to be finalised, and then some of those additional resources surrounding this paper will be held on the SHOT website. As soon as it's available, though, we will be sending that out via our newsletter and via LinkedIn. So other ways of finding out that information. But the really interesting paper for people to read. Thanks, Vicky. Yeah, following on from that, one of the things that we have most recently done, and hope you've seen this, and if you've not, please have a little look online. So SHOT have produced a patient transfusion app, and this is aimed specifically at patients to give them hopefully a complete understanding of what the whole transfusion process, what will happen, how to prepare, what kind of questions people will ask me, what will the transfusion look like. It's a really great app, completely free. If you just download it on there's a multitude of different ways you can get it from the App Store, Google Play. You can also, if you don't have a fancy smartphone, you can just go onto My Transfusion and you'll be able to find the website as well. So it is available as a website. And in those sections are specific points covered to do with this patient group that we're talking about. So we've got transfusing blood suited to you, we've got sections on consent, and we've also got safety checks, and there's a bit that talks about the different types of reactions as well. So it's really to empower patients, giving them back the information that they feel, so they feel safe and they feel protected, and sufficient knowledge within themselves as well for those transfusions. So there's a few more things that SHOT have done as well. So thank you. Again, I'd hope you've seen the SHOT transfusion safety standards. If you've not, please go and have a little look on the SHOT website, or you can follow the QR code. The standards are available in a variety of formats. You can see them in a standard web page. It's also available as a PDF. You can also load it as a Word document. If you can't find either of those things, please do get in touch and we can point you in the right direction. And they're built on 8 big pillars. These are replacing our SHOT recommendations that we used to produce every year. We will now have these transfusion safety standards, and this is going to be a long-term consistent plan. There's the 8 overarching umbrellas or pillars, but if you move on to the next slide, when we're particularly talking about this patient group, there are certain areas that are particularly covered. So you've got these 8 pillars, and then underneath each of those, you've got particular requirements. And these sections particularly mention either transfusion reactions or the patient groups, the haemoglobinopathy patients. So they are absolutely embedded in our safety standards to try and improve processes around this patient group, because as we've already seen, they can be very complex and have their own special requirements and needs. Thanks, Vicky. So like I was saying, the data we're looking at from 2024 was relying on us looking through each and every case, which is what we do anyway, but really picking out where we felt shared care was impacted on that error or event or reaction. Whereas from this year, beginning of this year, there is a whole new question in the dendrite system. So hopefully we can start to see where if shared care was involved, and where exactly were those gaps. Was it between the clinical areas to the labs, or vice versa? Was it externally or within internal teams? So we're really trying to hone in on where those gaps are, which hopefully will allow us to produce documents or resources to fill those gaps. Thank you, Vicky. One of the things we're also doing from the beginning of next year is we're going to we are going to improve these particular areas. So we're looking at the treatment pathways, and we're also looking at in particular, we're looking at the investigations in the lab as well. We're just scraping off the top layer and getting just a little bit deeper to find out exactly what's going on in the patient. But we're really looking at the different types of treatment plans and treatment options and what's being used. And then from the laboratory, we're particularly looking at the DAT. What sort of results were they? What sort of a little bit more information about the investigation to help us, again, to see what's happening out there in the clinical areas. We have a whole page dedicated to cumulative data. So over on the left, you can see that's just a snip of one of our website pages, and we've got all sorts. Haemolytic transfusion reactions has its own cumulative data page. It's one of those options over on the left, and it will take you to a page that's got everything to do with haemolytic transfusion reactions. So, for example, chapters, any resources, any documents, any external links that we think would be helpful. So if there's anything you particularly want to see about HTRs, please scan the QR code, or you can visit the shop website. It's under the resources section, and you'll be able to find that cumulative data page, all in a one-stop shop place for all the resources. So at the end of our webinar, from the presentations perspective, I think we're going to open it to the Q&A, so you can hopefully ask any questions. We've got our specialists and experts on the call.
Thanks, Nikki. Yeah, we've got some questions already. Thank you for everybody who's put questions in. We've got a couple that are very similar, and they're referring to the antibody cards, the physical antibody cards, and really wondering about understanding how patients carrying them, and whether the ward staff know about them, and really whether there's more education that's needed on them, and if there's anything else that we can do potentially for everybody involved, really, to be aware of them, or whether actually we need to move to something more digital.
Shall I come in for that first of all?
Thank you. Yeah, that'd be great. Thanks, Tracey.
I think we need everything. We need to use everything that's at our disposal. So an electronic solution is the ideal. We have the central database for antibodies, but that's not connected to any of the other parts of the patient's medical records. That's completely separate. We have information within individual hospitals, but again, that's not national. What we need is it linked to the patient's NHS record, similar to what's been done for allergies, where the patient's allergy record is available centrally to everyone. We need something similar to antibodies. Getting that is a challenge. So it's a challenge that's ongoing. We're going to keep trying to work towards, but it definitely is a challenge. In the interim, we do need to improve our patients' understanding and empower our patients. So I've worked in transfusion labs for a lot of years, and sometimes those patients definitely do understand the importance of their cards and they show it. And I have been involved in cases where that information has been key and sent to the laboratory in a timely fashion and been key to providing the right blood. But you're correct, everyone's different. Some people really cherish that card, and I've had requests from people who have, they've had it for many, many years, and they're worried because it's gone through the washing machine and they want a replacement. And we know other people, they receive it and it gets filed away and they never look at it again. So it's making sure we empower our patients so that they know to say, actually, I've got antibodies. It's important that you take notice of this. And of course, also educate our colleagues within the clinical areas that even if they're not involved in transfusion, this is necessary information that they need to capture and share. And it's that we need to get a multidisciplinary approach of all of us working together to try and solve it. There's not a one size fits all, unfortunately.
Okay, thank you, Tracey. The next question here is, are there any precautions needed in patients with antibodies if they require platelet transfusions?
I was so correct me if I'm wrong, and please correct me, Tracey. So I think a platelet antibody and the red cell antibody will be a different beast. Obviously, there can be residual red cells sometimes in platelets, but we don't cross-match platelets for patients. So in general, I think red cell antibodies are a concern when you transfuse red cells, and then HPA and HLA antibodies. So they're human platelet antigen, human leukocyte antigen antibodies are more of a concern for platelet products. But please expand, Tracey, on that.
So yeah, you're absolutely. So red cell antibodies, as in the extended red cell antibodies, your RH, your JKA, FYA, those kind of ones, like Vicky said, because the amount of red cells within a platelet component is so low, even if the patient had the antibody and it attached to those red cells, it'd be such a small amount of red cell destruction that it wouldn't affect the patient in the same way we would see for larger ones. And also for those cases, the patient will have sufficient red cells of their own, but that small amount of hemolysis won't affect them in an adverse way. What we do see with platelets and with the other plasma components is you can get hemolytic transfusion reactions due to the ABO antibodies. So obviously the ABO antibodies are in the plasma. If you transfuse them across the ABO barrier, you can get those donor antibodies that hemolyze the patient's red cells. So it's a little bit the other way around, but that's where we do see hemolytic transfusion reactions with plasma products and platelet products. They are rare, but they can be quite severe when they do happen.
Thank you. Anyone else? Or... Okay, thank you. So the next question is, has there been further investigations why there has been an increase in febrile reactions? Has it been established that the febrile reactions was due to the blood being transfused? Not sure who wants to take that one.
I can give a general answer. So any shot report that we accept as a febrile allergic hypertensive reaction, the experts, so we have working experts, medics in the field, will have determined that the link to transfusion is there. And it's not just due to that underlying patient condition. But I'm not quite aware of anything that we're doing about the increase or anything like that. I think, as we've mentioned before, there's sometimes an increase in reporting that goes on, and we see that more. But I'm happy for anybody else to weigh in on that one.
Anyone else?
So I'm not able to add anything to that.
Okay, great. Thank you. Over to you, Emma.
Thank you. So how can we develop our IT systems to improve care for HTR and haemoglobinopathy patients?
So I think it's making sure the information is available. So having flags and alerts on the system to alert us if a patient's a haemoglobinopathy patient or has a history of antibodies. Connecting our systems within hospitals as well. So some of the things, especially for the haemoglobinopathy patients, that might be on your patient information system, and it's making sure that comes across to laboratory information system if those two don't have direct links. So it is making sure we join everything up and we make use of those alerts. It's been discussed in the IT chapter that, we also need to make sure we respond to those alerts on the IT system. They're not just there. They're not easy to just enter and get past. That people have to take the time to read and respond to them. But it is just joining everything up and making sure those systems are used where possible. There was a survey done, I think it was 2014, of laboratory information systems, and only half of them had the facility to flag if your patient had a haemoglobinopathy. Hopefully it's improved since then. We're talking just over 10 years ago. But we need to make sure those systems are available on any new IT systems that get installed, and that we, make sure that's included in our specifications. And I think that's the key, making sure that we use the flags, they're there, and we link them up and make sure that they're correctly populated.
Okay, thanks, Tracey. Vicky or Nikki, anything to add to that?
I was going to say that, I mean, lots of clever EPRs now are really good at having that like you say, that interoperability. You might flag something on the clinical side that has a capability to then alert the LIMS in some way. So it's just, like you say, maximizing the potential. That there are some out there that already are capable of doing that. I'm not saying all, but those clinical systems, you are able to, if, like you say, Tracey, if a new medication is prescribed or a particular type of chemotherapy is used, is that then able to then flag in the LIMS that makes a change to someone's requirement. So it's making those flags clear and understandable, like Tracey said. Sorry, Vicky, I jumped in. Were you going to add
No,
as
it's
well?
fine. I was just thinking with the requesting as well, we've seen some systems with the ability to make that a mandated question that we ask, so kind of prompts that thinking and prompts those decision pathways, and even to do with like appropriateness of transfusion and things like that. But just to go back to what Tracey was saying, like about the flags and stuff, I think it's a really key point, because quite a few of the shot reports that we see, the information is there, but it's not upfront, so it's hidden in a comment section. somewhere, and there's no way to get it to come up front and centre when people are issuing components. So definitely a lot of work to be done. I think people are trying, and it's moving the right way, but it's definitely in progress.
And it relies on that shared care. Going back to the shared care, you can have all the best flags in the world, but if you're not informed in a timely manner, then you can't update that, which you won't be able to provide the patient with what they need because you're just not aware of it. So it's a combination of the two, isn't it? That if you have got a shared care link between trusts or organisations or even departmentally, that communication is really good and really prompt.
Sorry, can I just add one more thing to that? It's also seeing the bigger picture as well and making sure that everyone understands all of the available information. So the example that Nikki presented of the shared care where a patient went in for a knee, quite often you'll see on request forms going to the laboratories, the reason for the transfusion, knee surgery, and they forget that the patient's also got a haemoglobinopathy or something else as well. And we see it a lot in pregnant patients as well. The reason for they're being seen is because they're pregnant, but we need to know that background diagnosis as well. And it's making sure you see that big picture. It's not just why you're treating that patient at that point for that, at that moment, is the whole diagnosis and their whole clinical history.
Great, thank you. Thanks very much, Tracey. I think we've got time for maybe a couple more. So, how do we prevent haemolytic transfusion reactions from occurring?
So some of them, unfortunately, are going to happen. And there's some times that we need to just accept that the risk of a transfusion reaction is less than the risk of the patient not being treated. So, for example, in emergency transfusions, you will have to give the best match. You might not have time to do the full antibody investigation and give antigen negative blood, and we should never withhold life-saving transfusion because we're worried about the risk of a transfusion reaction. When I was a young trainee many years ago, it was taught to me that actually you need to, you can treat a transfusion reaction if it happens. If the patient dies from bleeding out, you can't then treat that. You can't get them back again. So you do have to make sure that you balance that risk. And unfortunately, those cases are always going to happen where we have to transfuse until we get to the point where we've got, fully laboratory grown red cells with no antigens on them at all. But I think we all know we're a very, very long way away from that. What we need to do is reduce the ones that are avoidable. So the cases where we know the patient's got an antibody or that's on record, we need to make sure that we get that information available so we can reduce it. So that the avoidable ones that we can do something about, we can stop. But those unavoidable ones where we have no choice but to give antigen negative blood, we manage. And it's not just emergency transfusions, it's also those cases where they've got very rare antibodies and antigen negative blood's just not available. So, I'm thinking of things like your anti-U's or anti-Vels where it's frozen blood only or best matched blood. So, yeah, I don't think we're ever getting a situation, unfortunately, in my lifetime where we can avoid them completely, but we do need to manage them and reduce them. That is within our gift.
Okay, thank you, Tracey. Just to let you know, we have got Sharif and Anicee in the background, but they're having some IT difficulties, but they are busy trying to answer questions there by text. So that's great.
I think Emma, Joe has managed now, so he's on the screen.
Oh,
so I don't know if Joe
welcome, Joe. Welcome. Probably only got time for one or two more. So the next one is, why do patients with thalassemia have more FAHA and patients with sickle cell anemia have more HTR?
I was just looking at this, actually, the numbers. So it looks like there was a similar number of FAR for both thalassemia and sickle, whereas there's just a much higher proportion of HTR for the sickle patients. So I think that's the difference rather than there being more for the FAR. I think without knowing how many patients have been transfused in the thalassemia and sickle group, it's difficult to know, what proportion there is in each, but I'm not sure if there's a definite difference there.
What we do see and what has been published is that patients with sickle cell anemia tend to produce red cell antibodies at a higher rate than other chronically transfused patients. So in most chronically transfused patients, which includes thalassemics, they tend to be immunized at a rate of between 2 and 5%, where in the population of sickle cell anemia, that's been reported up as high as 30% immunization rates. And a lot of the theory behind that is just the differences in the ethnicities of the donor populations and the patient populations. That is a working theory, but we definitely have seen that there's high immunization rates in sickle patients. And because of the higher rates of red cell antibodies, you've got a higher chance then of going on to have a hemolytic transfusion reaction or antibody-mediated transfusion reaction.
Thank you. Over to you, Claire. We've probably got
Thank
time
you.
for one quick one.
Yeah, I was just having a quick look at any that I know Anicee's been answering them there. Joe, I don't know if you want to, I know you've had trouble getting on. I don't know if there's anything else you've wanted to capture of any of the questions that we've answered, or if there's anything else you wanted to follow up with in the last minute or so.
I suppose I always want to make the point about all of the risk of transfusion in sickle cell and about how to avoid it. Firstly, the best way to avoid it is to avoid transfusing the patient. So obviously patients with sickle sometimes need transfusions, but there's a lot of times where the indication is not very clear, or we see patients that have been transfused where possibly transfusion could have been avoided, you know, and I think that's one of the key points really, is making sure, is the transfusion indicated? Is there a clear you know, clinical reason for the transfusion? Have you consented the patient? You have to make sure all of those bits are in place before you go ahead with the transfusion. Yeah.
Okay. And a very super quick one, probably Joe, if you don't mind. What specific requirements do patients with a haemoglobinopathy require?
Well, for sickle cell, they are they need to be ABO matched, RH, D, C, and E matched, and KEL matched. So that's the current national guidance, and internationally, that's what people do as well. There is a lot of research looking at further extended matching, and there's the HeMatch project in England as well, which is looking at genotyping patients and seeing if we can provide more closely matched blood. But at the moment, that is still at the research stage, and there's lots of questions about whether that would be possible with the resources and things, but it is certainly an ongoing question at the moment.
Okay, thank you very much. And as we said earlier, sadly, we are running out of time. We've got about 3 minutes left. But if there's any burning questions that we weren't able to answer today, please do inbox them to SHOT, and we will do our best, and we'll pass them on to our experts to try and answer those. So thanks again for all those great questions. Just a reminder, if you do want to send us the questions, the email address here is shot@nhsbt.nhs.uk. In the last few minutes, we're just going to do a live poll, and we'd really appreciate you taking a few minutes to complete this, as it helps to guide our future resources and webinars. So you'll see that poll launching in the background there. It will appear on your screens for you to submit your answers, and then you need to press submit at the end. While you're answering those questions, I'd just like to remind you that the session's been recorded and it will be uploaded to our website within the next week or two. And that's really helpful if you want to re-watch it, or you're aware of members of staff who couldn't be with us today, but that it would be beneficial for their learning to watch it retrospectively. And we really do appreciate your feedback and comments and suggestions about haemovigilance and the work that SHOT do. So please get in touch with us by phone or by email. Our website is www.shot.org, and it contains reports and lots of resources which are freely available to help with your transfusion and education and training activities. And the same information is also available on the SHOT app, which can be downloaded, and you just do that by putting SHOT UK in the search button to find that app. So please keep an eye on our website, app and LinkedIn for forthcoming webinars and events. And finally, a huge thank you to our speakers today, and apologies, we can never foresee these IT difficulties, but glad you were all able to join sort of eventually in some form. And thanks a lot to the admin team who were busy behind the scenes to ensure the smooth running of these webinars, and to all of you for joining us today. And we do hope to see you at a further event, a future event very soon. Thank you very much, everybody.